Hi, my name is Rachel Thompson. I'm the consultant Admiral Nurse for Lewy Body Dementia, and I'm delighted you could join us today for this summer school session about understanding Lewy Body Dementia, supporting families. So this is the session plan. I'm going to give you an overview of what Lewy Body Dementia is, looking at causes and what we call differential diagnosis, specific diagnosis. I'm going to talk about Parkinson's disease and the relationship between Parkinson's disease and Lewy body dementia. I'll also talk about assessment and diagnosis, recognising specific symptoms. We'll touch on delirium because there is a kind of link between delirium and dementia with Lewy bodies. I'll then go on to talk about treatments and management, some of the common difficulties that are experienced, and the best ways we can support families who are affected by this particularly difficult cause or type of dementia. So the session is going to be hopefully a little bit interactive, so please do stay engaged. So just as background, what is dementia? You're probably all familiar with this, but dementia is an umbrella term for a group of symptoms that include a progressive loss of memory, judgment, reasoning, communication, general functioning, changes in mood and behaviour. And as dementia progresses, it eventually leads to increasing problems with eating, drinking, mobility, communication, continence and recognition. There are a number of causes and types of dementia, too many to mention in detail, but some of the main ones are covered here. So Alzheimer's disease, you're probably familiar, is probably the most common cause of dementia, accounting for approximately 60%. Vascular dementia, we think about 20%. And Lewy body dementia here, we've got the figures here that's approximately 10 to 15%, but we think actually that it could be more because often Lewy body dementia may be misdiagnosed. Now, I've mentioned mixed dementia because many people, particularly as they've lived with dementia for a long time, may have a combination. And it's usually Alzheimer's and vascular, but sometimes it can be Alzheimer's disease and Lewy body. And I'll talk about that in a little bit more detail shortly. There are some types of causes that are more likely to affect younger people. I'm not going to go into detail because there is a separate session on younger onset dementia. So please do feel free to watch that. And there are lots of other less common types. Again, really we're talking about Lewy body dementia today, but there's just some here there for you to be familiar with or to, if you want to look at more detail. So let's start with a picture of the brain. This is a simple image of the brain, which highlights some of the different areas of the brain and the roles and function they take. Now, I think this is helpful because sometimes when we see changes in functioning, it helps us understand what might be, which area of the brain might be affected and why actually these are happening. The frontal lobe is the area, the blue bit that's illustrated here, controls thinking, planning, solving problems and behaviour. Now, in Lewy body dementia, we think this part of the brain can be affected, particularly what we call executive functioning, problems around sequencing and coordinating and planning. The parietal lobe is the yellow area that controls awareness of surroundings and coordination. We think also can be affected in Lewy body dementia, particularly with visual spatial difficulties. And also the pink area, the occipital lobe at the back of the brain, particularly important. We think in relation to the experience of some of the symptoms of hallucinations that some people with Lewy body dementia can experience. So the other area that's also we think is significant is the cerebellum. Now, this is the area that controls our balance and movement. And we'll go on to talk about how this is also affected in Parkinson's. Now, the area, the green area, the temporal lobe, which hosts, as you can see, the hippocampus, important for memories, and the amygdala, important for emotions, and also language and speech. Now, this area can be affected in Lewy body dementia, but often perhaps a little bit later in the condition, although not always. So Lewy body dementia, the most common disease you've never heard of. This is a phrase that's coined by the Lewy Body Society, which is a UK-based charity whose aim and mission is to increase awareness and improve research into Lewy body dementia. We think approximately 100,000 people with Lewy body, 100,000 people have Lewy body dementia within the UK. That means that it's the second most common type of neurodegenerative dementias, and I'll go on to talk about that in a minute. But the important thing here is that Lewy body dementia is an umbrella term, and it includes both dementia with Lewy bodies, which is where cognitive changes happen first, but also Parkinson's disease dementia. And this is where somebody has an established diagnosis of Parkinson's and may go on to develop dementia as time goes on. Now, you will see here that it's about 30% overall. So not everybody with Parkinson's will go on to develop dementia, but the longer you live with Parkinson's, the increased risk you have of developing dementia. So I mentioned it's the second most common cause of neurodegenerative dementias. This is important. Vascular dementia isn't neurodegenerative, so this is why it's highlighted as the second most common cause. And Lewy body dementia is really caused by the normal buildup of protein, a particular protein called alpha-synuclein, which leads to brain cell damage in certain areas of the brain. And some of the core symptoms are highlighted here. We will talk about these in more detail, but just quickly as an overview, what we often see are problems with attention and visual spatial perception, sleep disturbance, and particularly REM, rapid eye movement, sleep behaviour disorder. And this is what's sometimes known as dream enactment, where people will act out their dreams, essentially. So people's arms and legs may flail around during the night and people are not aware this is happening. People may experience visual hallucinations. People can experience hallucinations in other modalities, such as hearing or sense or smell, but hallucinations visually are the most common symptom. People also may experience problems with movement or motor control, which are linked to the Parkinsonism symptoms. A key feature of Lewy body dementia is fluctuations, particularly cognitive fluctuations in attention and concentration. And then after that, we've got a range of what we call autonomic symptoms, these are the symptoms that are controlled by our autonomic nervous system. So it can include things like constipation, increased urination, excess sweating, loss of smell and taste, and also some other neuropsychiatric symptoms such as delusions. These may be linked to the hallucinations, but things like anxiety and depression and apathy are also quite key. Now, this type of dementia, which we see as being quite complex, does seem to progress quicker than other types of dementia, and this is probably just due to the combination of the Parkinson motor symptoms and the cognitive changes. So what are Lewy bodies? There's a picture up there in the right hand corner, which is what it might look like, but this essentially Lewy bodies are abnormal protein deposits that disrupt the brain's normal functioning. They were actually first discovered by a neurologist called Dr. Frederick Lewy, who they're named after, who discovered these in a Parkinson's patient. And as I mentioned, they're made up mostly of a protein called alpha-synuclein. Now, what happens is alpha-synuclein, which is a neurotron, which is a protein that's present in our brain normally, it can form into clumps, and this is where we lead to problems, which essentially leads to change in function or death of the neuron, and also a loss of production of two important very neurotransmitters. So acetylcholine, which is something that also gets affected in Alzheimer's disease, but also importantly dopamine, and this is something that's different in Lewy body dementia. So terminology, and I'm just going to mention terminology because it can be confusing. You will hear different terms or diagnoses being used in Lewy body dementia. So if we see that the Lewy body disease is the underpinning cause, caused by these clumps of alpha-synuclein in the brain. Now, these can lead to Parkinson's disease. And some people, if you see on the left-hand side of the slide, some of these people can go on to develop Parkinson's disease dementia, or it can lead to dementia with Lewy bodies. And the key is where the disease occurs, which parts of the brain these Lewy bodies are located, and the problems they therefore cause. So I'm just going to talk a little bit about Parkinson's disease, because it's quite helpful to think about where the relationship is and what are some of the symptoms. So Parkinson's disease is a progressive neurological condition, affects approximately 145,000 people in the UK, but probably more. But the main type is idiopathic, which means that the cause is unknown. There are some other causes of Parkinsonism, vascular, perhaps drug-induced, which is as a result of neuroleptics. And there's some other rarer types, and you may have heard of some of these: Wilson's disease, progressive subnuclear palsy, multisystem atrophy, normal pressure hydrocephalus. So I'd just like to share a short animation from Parkinson's UK, which gives you a really nice overview and summary of Parkinson's disease. So let's see how this works.
Parkinson's is a condition that affects the brain. It develops when cells in a particular part of the brain stop working properly and are lost over time. These brain cells produce an important chemical called dopamine. The brain uses dopamine to send messages to help control movement. Everything from walking and talking, to writing and even smiling. Eventually, the brain cannot make enough dopamine to control movement properly. This is when symptoms start to appear. These problems can be subtle at first, like handwriting becoming smaller. But as more cells are lost, problems with movement get worse, and some people may also experience other symptoms. We don't fully understand why dopamine-producing cells are lost in some people and why people get Parkinson's. But our researchers are working hard to find ways to protect these precious cells so we can develop better treatments and one day a cure.
So a useful illustration from Parkinson's UK there. So just to emphasize this point, that the role of dopamine in Parkinson's disease, you will see on this slide the image with a normal neuron at the top producing lots of dopamine, which gets taken up by receptors and helps with normal movement. Whereas a Parkinson's affected neuron further down below, much reduced amount of dopamine, and this can lead to movement disorders, principally tremors, slow movement and rigidity. And these are some of the common symptoms that we see for somebody with Parkinson's. So I'm just going to touch on some of the treatments for Parkinson's, not in massive detail, but they're helpful because some of the people that have Lewy body dementia may be also being treated for Parkinson's, particularly those people with Parkinson's disease dementia who may have had treatments for a number of years. So some of the main treatments for Parkinson's: physical exercise, lots of really good evidence, may need to be adapted as the condition progresses, but can be really helpful in managing and allaying some of the motor symptoms. There are three main types of medication. The first type is a levodopa-based medication, which essentially these increase the amount of dopamine in the brain, often a combination of two types of drug, levodopa and benzorazide, and the combination of these will help work in the blood-brain barrier. The other type is dopamine agonist, which acts as a dopamine substitute. And then also we've got something called monoamine oxidase and COMT inhibitors. And what these do is they block the enzymes that break down dopamine. So depending on the symptoms and the particular presentation of the person with Parkinson's, these medications will be used and altered and adjusted, and may need to be increased as the condition progresses. For any of you who know much about Parkinson's, you will know that getting the medication on time is really crucial, because people have what we call these on or off periods. There can be interactions for some of these medications, and also some side effects. So these do need to be monitored and adjusted very, very carefully. There are other therapies that are also really important: physiotherapy, occupational therapy, speech and language therapy can be particularly helpful for people with swallowing or speech problems. Sometimes people have problems with the softer speech and articulation. For some people, deep brain stimulation may be offered, often younger people, or where medications are thought not to be as effective. If people are interested and want to find out more about the treatments, please do have a look on the Parkinson's UK website. There's a really useful link about some of the drug treatments there as well. So where are Lewy bodies found? And this is important because it will help us understand the symptoms that occur. So in Parkinson's disease, Lewy bodies are usually found in the midbrain and the brainstem. And you'll see here highlighted in blue, these are the areas of the brain that are involved in movement and balance, but also in the brainstem. This is the area of brain that's really important in regulating sleep, in maintaining alertness and controlling the autonomic nervous system, so such as bladder, bowel, blood pressure, temperature, swallowing. So if somebody's got Lewy bodies in this area of the brain, you can perhaps see why some of the symptoms that people present with are starting to emerge. For people with Lewy body dementia, then what we're now seeing is that the Lewy bodies are occurring in the pink areas here, as well as the blue areas. So the cerebral cortex, important in information processing, thought, language, olfactory pathways. The limbic cortex plays a major role in emotions and behaviour, and also the hippocampus, which, as we previously mentioned, is essential to forming new memories. So I touched on this, that often people have what we call a mixed pathology. Now, the research seems to suggest that some people with what we call pure alpha-synuclein pathology, or sometimes seen with people with dementia with Lewy bodies, can happen. But however, a lot of people we think probably have what we call a mixed pathology. And the mixed pathology is a mixture of Alzheimer's pathology, which is the beta amyloid and the tau, as well as the alpha-synuclein. Now, for people with this mixed pathology, it would seem that this leads to more advanced dementia, so people seem to progress quicker. There was lots of research undergoing at the moment, just trying to find out what any possible genetic links. Currently, the thinking is that most cases are still sporadic, but there may be some mutations in certain genes, as illustrated here, but there's lots of research underway to help us understand this much more. So here's a graph that illustrates a survival analysis of people with dementia with Lewy bodies and as compared to Alzheimer's disease. And you will see here this the survival analysis takes into account, it counts for age, antipsychotic prescribing and frailty. But despite these, there is still a faster progression for people with Lewy body dementia. Again, not everybody, because it depends on the presence of mixed pathology or not, but you will see there's still quite a significant difference. So we've talked about some of the symptoms, some of the etiology, the background, the causes. What I'd really just now like to do is share a short clip about what it might feel like to live with Lewy body dementia. Here we go.
I'm not dwelling on things too much. I think that you can be, you know, it's very easy to be Mr. Gloom. It's not physically painful, but it's mentally, you know, it's difficult to do things.
Dementia with Lewy bodies is the second commonest cause of dementia. It shares a lot of symptoms and features in common with both Alzheimer's disease and with Parkinson's disease. So it sits really in between the two. DLB causes problems with thinking and memory, and also several other features that affect much more wider body systems.
In general, that the executive functions, which is making multiple decisions or multiple tasks, or like doing the complicated things, for example, finance, or sometimes making plans or schedule. It's becoming very difficult.
Patients can complain of visual hallucinations where they see people or animals that aren't there.
The very first hallucination that I had was a samurai warrior attacking me on my bed, and that was really quite upsetting.
And another symptom would be relating to Parkinsonism, which is freezing. Freezing means it's difficult to initiate the walk, and also sometimes it affects the speech as well. Try to speak, but what mouth doesn't move. We try to arrange exercise class or speech therapist, those kind of specialist needs. We need help.
Sleepwalking and talking. That's probably one of the key problems that I have.
Roy thinks he's sleeping, but actually through the night, Roy is continuously walking, sleepwalking and talking.
When somebody gets a diagnosis of dementia with Lewy bodies, the first thing is to seek out information and support for the family. It can feel quite traumatic to get such a diagnosis, but actually often that's the beginning of getting the right support for the patient and for their family.
We have got very strong local support network from medical professionals like GPs, consultants, Parkinson nurses, and also neuro rehab team.
As part of the Rare Dementia Support Group, we have a Lewy Body support service which meets twice a year for education and support for DLB. One of the strategies that we found to be really helpful as part of Rare Dementia Support is putting patients and carers in touch with each other. So peer-to-peer support is in of itself really helpful. Just to know that you're not out there alone, that there are other people who are going through the same things.
Don't give up. Don't give up. You've been given a life. It may be one that's got some problems to do with it, but so have many.
Having this kind of experiences is really made me realize that the society we are in is very actually very kind. I mean, we didn't sign up for this journey, or we didn't apply for this journey, or we didn't plan, but this journey took us to the different directions and then give us a chance to see the nice side or a kind side of the society we are in.
So a really powerful illustration of how it can directly affect both the person with the condition, but also the family carer. So I talked about the umbrella term for Lewy body dementia, and there's something called the 1 year rule. Now this helps define, it was produced by Ian McKeith and colleagues in Newcastle, and it helps understand the difference between the two different types. So as I mentioned before, just to help reiterate, Parkinson's disease dementia is where the dementia starts 1 year or more after a fairly well established Parkinson's disease, whereas dementia with Lewy bodies, DLB, where dementia occurs before or sometimes at the same time as Parkinsonism or within 1 year of the onset of motor symptoms. So sometimes we need to kind of ask questions, because it's not until we ask people and get them to reflect back on the presentation of symptoms that people kind of know that perhaps some symptoms started before others. So how can we diagnose dementia with Lewy bodies? So we've talked about Parkinson's disease dementia is where you will be kind of seeing, as I've said, somebody with Parkinson's disease and then going on to develop cognitive changes. In order to diagnose dementia with Lewy bodies, what we're looking for is cognitive changes that are significantly affecting day-to-day life and function, and specifically attention and visual spatial difficulties. We'd be looking for core features, and what's required to make a probable diagnosis is 2 or of the following, or 1 plus an investigation. So the core features are fluctuating cognitive impairment, and this can be from moment to moment, hour to hour, day to day, in about 80% of people with DLB. Now, and this can be quite frustrating and quite puzzling, particularly when professionals see somebody and perhaps they're seeing somebody at a good moment, whereas, you know, that can change quite significantly. Another core feature is these recurrent complex visual hallucinations. Key thing here is that they're recurrent, they're often of the same theme, and they're complex. They're three-dimensional, they're often of people or animals, and may or may not be distressing, but in about 70 to 75% of people. There may be spontaneous features of Parkinsonism, so in people with DLB, we may not see all of these straight away, but eventually as the condition progresses, the Parkinson features will become more pronounced. And then the other core feature is what we mentioned before, REM sleep behaviour disorder, in about 75% of people. Now, notably, this often occurs years before other symptoms, so this is why history taking is really helpful. And it may be that people will say, oh, actually, yes, they used to have nightmares or dreams or used to move around in the bed. So getting that collateral history from the carer or the bed partner is really important. There are some other supportive features. So, and these are often linked to, the first group are linked to the autonomic nervous system. So postural hypotension, this is a drop in blood pressure from either lying to sitting or sitting to standing. People may feel dizzy and may lead to kind of problems with balance and falling. Urinary problems, particularly at night, this can be a problem. So bladder sensitivity, urge incontinence. We get a slowing of the gut, which can often lead to constipation and may need treating with laxatives. There can be problems with speech. There can be excess of saliva or swallowing problems linked to the Parkinson features. There may be loss of smell of taste. And there also, as I kind of touched on, that people may have other neuropsychiatric problems. So anxiety and depression, partly we think perhaps to do with people's insight into the changes. Apathy can be quite a significant problem, and also delusions, which may be linked to the hallucinations that people are experiencing. So this, for assessment and diagnosis, for a possible dementia with Lewy bodies, you may have one of the core features, and if diagnosis is uncertain, then it's recommended in the NICE guidelines that this is confirmed with an indicative biomarker or an investigation, and these are listed here. So particularly a SPECT, PET or DAT scan, these measure the dopamine uptake. You may ask for an MIBG, myocardial scintigraphy imaging, or in fact somebody may have REM sleep behaviour disorder confirmed by polysomnography. Probably in practice, you'll see the SPECT or the DAT scan is the most commonly used. Prodromally, so before symptoms start, we do find, as I've mentioned, that sleep behaviour disorder may occur several years before the onset of dementia or Parkinsonism. And the phase may include mild cognitive impairment, delirium, and psychiatric symptoms. So these are important things when we're kind of finding out, you know, what happened when we're collecting history, or perhaps we've got somebody with mild cognitive impairment presenting in a memory service, for example, that it's really important that we ask these questions about the psychiatric symptoms, sleep changes, and perhaps an increase or incidence of delirium. So I'm just going to talk about delirium because it is quite important. So we know that people with dementia are increased risk of developing delirium that may be caused by infections, constipation, dehydration, vitamin deficiencies, pain. For people who want to find more, there's a really useful leaflet on the Dementia UK website about delirium, how best to manage that. People with repeated deliriums are also increased risk of developing dementia. So, as has been mentioned, delirium may be a common symptom in early stages of dementia with Lewy bodies, and so may be what we call a prodromal feature. Now, delirium and Lewy body dementia, or dementia with Lewy bodies, what we will see for both of these is a global impairment of cognition, fluctuations in attention, and perceptual abnormalities. And so that's why it can be difficult to differentiate, but there may be some slight differences in presentation. I'm just going to give you an overview of what they are. So I've highlighted in blue, there's quite a lot of information on this slide, so apologies, but you will see on the left is delirium. So what we'll see is an acute or sudden onset, whereas dementia with Lewy bodies, the changes will be more gradual and progressive. Another area of difference may be with people with delirium may still have visual and auditory hallucinations or delusions that can be quite florid and quite distressing. With dementia with Lewy bodies, they're usually more recurrent and structured, so they perhaps have a theme, whereas perhaps with delirium, they're perhaps more interchangeable or variable. The disturbance in sleep-wake cycle in delirium may be really variable, so people may have a hypodelirium where they're more sleepy, or hyperdelirium where they're more active, whereas DLB, we're probably looking out for this REM sleep behaviour disorder, the dream enactment, the loss of control of movement during the night, or sometimes these nightmares, these night terrors, sometimes called. What's really important here is that in delirium, some of the symptoms may be responsive to neuroleptics, whereas for dementia with Lewy bodies, there can be a severe neuroleptic sensitivity. Now, not for everybody, but we think for about 50% of people with dementia with Lewy bodies can have a significant reaction to what we call the typical antipsychotics, and that would include medications such as haloperidol. So if we have somebody presenting with these, what we're not sure whether it's delirium or dementia with Lewy bodies, as you can see, it's really important that we're very cautious about the use of antipsychotics. And so we would definitely be avoiding haloperidol for somebody with this diagnosis. So we're going to stop for a moment and have a poll just to check in with how you're doing with remembering a lot of the information I've been sharing. So after that poll, I hope that was okay. Helps embed some of the knowledge that I've been sharing. Please don't worry if you're getting things wrong at this stage. This is all part of our learning. I'm going to now go on to talk about balancing symptoms and treatments, and it is a real balancing act between treating the cognitive and neuropsychiatric symptoms, but also the Parkinson symptoms that people can experience. Both medication and psychological, social, environmental treatments are really important. So it's not either or. So this is where I'm going to mention something called the Diamond Lewy Management Toolkit. Now, you can find information about the Diamond Lewy just by, in any search engine, putting in the words Diamond Lewy. This is a toolkit that was developed by the researchers and clinicians in Newcastle and Cambridge. And it's a really useful tool, both for assessment. They've got some assessment toolkits on there, but they've also got some guides about how to manage specific symptoms. The image on the left gives you the overview. In the middle, you will find there are some pages around specific symptoms and treatments that may be suitable based on some of the understanding and the research that has been undertaken. So please, if you're interested, do have a look at that in more detail. But I'm just going to give you a little bit of an overview of some of the different symptoms and how we can support and manage people who are experiencing these. So initially, cognitive symptoms. Now, for cognitive changes, we would always recommend that any kind of things that are helpful in any other types of dementia or causes of dementia where people are having cognitive difficulties. So memory aids, social stimulation, cognitive stimulation therapy, all still equally helpful for people with Lewy body dementia. We would recommend cholinesterase inhibitors, And sometimes these can be used by themselves, but as the condition progresses, memantine can be used, or in fact, memantine may be used if somebody can't tolerate a cholinesterase inhibitor. And particularly, we'll find in the UK, donepezil and rivastigmine are used most commonly. So those are the cognitive symptoms. The neuropsychiatric symptoms, the hallucinations that I mentioned, this is one of the reasons why cholinesterase inhibitors are recommended, because it seems that hallucinations can really respond very well to cholinesterase inhibitors. So definitely worth trying. Think about environmental changes. So if people are having a visual perceptual difficulty or experiencing visual hallucinations, or in fact auditory hallucinations, think about how you can adapt the environment to reduce the stimuli, to remove things that may be misperceived. I'm going to talk about that in a little bit more detail soon. Really importantly, think about the reduction of Parkinson's medication. Now, some of the levodopa medications can increase hallucinations, and also the dopamine agonists. So these are why these medications we need to be really cautious. Dopamine agonists are not often recommended for people with dementia with Lewy bodies. But if somebody's on them, and they start experiencing hallucinations, you may need to consider or ask for a review of medication to see if they can be reduced, to see if that helps reduce some of the experienced hallucinations. Psychological and social interventions are also equally important. So helping offer reassurance, reducing distress. And if people have got things like anxiety or depression, think about some of the psychological interventions that may be helpful for people. For sleep hygiene, really importantly, think about trying to reduce stimulants before somebody goes to bed. Think about looking at the environment, make it calm. Keep a sleep diary. This is really helpful because it will help find out, do any changes to the routines or the patterns make a difference to somebody's sleep cycle. For REM sleep behaviour disorder, some medication may be helpful, and again, information can be found on the Diamond Lewy Management Toolkit, but particularly melatonin, may be helpful and may be tried, or clonazepam, that's another medication that may be helpful. So here's the NICE guidelines about pharmacological management of DLB. So it recommends that donepezil or rivastigmine is offered to people with mild to moderate dementia, but also may be considered for people with kind of more advanced or severe dementia. Also considering memantine for people if the cholinesterase inhibitors are not tolerated or contraindicated. So I'm just going to talk about hallucinations and visual perceptual changes, because it is helpful to think about why this happens, because they can be very distressing for people. So just thinking that vision is an active process and is informed by previous experiences. So for all of us, this is important. So here you'll see a picture of a brick wall. So I'm going to show you the next picture. Now you will see, now here is highlighted a cigar. Now, you may not have seen that initially, but of course now it's quite difficult to see. Look at the first picture without seeing the cigar. So you'll see we are informed by our learning. For people with particular problems with the brain and in Lewy body dementia, changes in the brain can lead to misinterpretation of visual information. So it's really important that we rule out other things that are making it harder. So ensure regular eye checks. As I kind of indicated, look at the environment. Look at things like, is somebody getting distressed by a mirror because they're misperceiving, they're not recognizing an image. Highly patterned carpets or curtains can be really quite confusing, and people can see things in them that may kind of them feel kind of quite distressing. Think about changes in flooring, and consider highlighted borders that may make things easier for people to differentiate. There's some images here that kind of just show you what are called illusions and pareidolia. Pareidolia is where we see faces in things where there isn't really a face. Now, this is something that we perhaps all do. So if you look along, you will see that perhaps The first one is fairly obvious. In the middle, you'll see, perhaps you can see the face in the clouds. And I don't know if you can see the face in the tree bark there. This is something that we often all do, but for some people where this is becoming problematic, then this may become quite, they may be seeing them much more often. So for people with Lewy body dementia, really what we're talking about is something called complex visual hallucinations. And as I've said, they occur in about 70 to 80% of people. They're usually complexed, they're well-formed, three-dimensional and recurring. They do seem to be more common in the evening at night. And this is perhaps because, you know, our vision isn't as good, perhaps the lighting isn't as clear, and people are more tired. Now, they can include something called passage hallucinations, which these are things that occur at the side of vision. So perhaps somebody may see something and think, oh, was that a person? Or something called presence hallucinations, where this is where somebody really feels like there's somebody is nearby, but when they look, there's nobody there. As I've said, they're often, when they're very three-dimensional, they may be animals, maybe people, maybe children. Now, sometimes these can be actually not that distressing. People may just acknowledge them and not be that distressed, whereas at other times they can really be quite distressing. So, for example, if somebody's seeing somebody perhaps outside that they're misperceiving a tree or a bush, they think it's a person, they may feel like they're being watched, and so therefore this can really be quite upsetting. We've got a new leaflet that's available via the Lewy Body Society, but also Dementia UK, about tips and suggestions about managing hallucinations. But just some of the tips here are, you know, ask the person, if you think that they're seeing something, but they're not actually admitting to it, then just perhaps ask them gently, you know, do you ever see things that others can't? Do you think your brain is playing tricks on you, or your eyes are playing tricks on you? Recommend, if they've got insight, that they might want to check out the reality with others, people that they trust. Importantly, if somebody doesn't really have insight, then offer reassurance. Try to acknowledge this is an experience that's very real to them, and don't ignore and invalidate, because that may just make the person more upset. There is a film that's been developed by Rare Dementia Support and the Alzheimer's Research UK, which gives you a really useful insight about what it feels like to experience some of these symptoms. I'm hopefully going to play you a short clip.
Can I talk about my family? My pretend family. The children live with me. Pretend little children. They didn't talk. I used to say, look, we could have such fun together. Why don't you talk to me?
I'd ask questions like, well, what do they wear? And then she said, that's a good question, because I don't really know what they wear. And I'd find food around the house.
And I treated them like proper children. And I gave them each a little biscuit at milk time. I mean, they really were there. I gave them pen and pencil and see if they could write or scribble or anything. But they were still exactly as I left it when I came back.
I think we often forget the nature of the person, but what we're actually seeing is an amazing woman trying to care with all the love and attention on these children.
This family meant a lot to me. I believed it wholeheartedly.
So for people who want to watch that in more detail, then please do just do a search for Another Presence, a film about dementia, hallucinations and altered perceptions. Really useful insight into how it feels, and hopefully that just gives you a glimpse. So I'm now going to talk about delusions and something called Capgras, which is another of the features or symptoms that people may experience and can be, again, particularly distressing. So a delusion is a fixed false belief that's not based on reality. And as I've kind of mentioned already, may be linked to hallucinations or misperceptions. Now, something that we see, particularly in Lewy body, is something called Capgras, which is a delusion of misidentification. This involves somebody seeing, this is essentially a person seeing several versions of a person, and they may be good or they may be bad, but they think somebody is being replaced by an identical looking imposter. So as you can imagine, particularly for kind of family carers, this can be really quite distressing. We have again developed a leaflet, so again can be downloaded from the Lewy Body Society website or Dementia UK. Please do have a look because it may be helpful. But there's some general tips, again very similar to hallucinations, thinking about not arguing or disagreeing. Because it's often a visual, perceptual difficulty, you may want to use a voice to increase recognition. We often say perhaps think about, you know, going out of the room and walking back in again. Using distraction, perhaps talking as you come into a room if you're the person who's been seen as an imposter. The general approach of being calm, being aware of tone of voice, and using simple short sentences that can really help people feel a little bit more reassured and less frightened. So I'm going to now move on to some of the other symptoms, and we can't go into them in huge detail, but we mentioned a whole range of autonomic nervous system symptoms, and here are some of the treatments or possible treatments that could be tried. So for constipation, you know, thinking about laxatives, about diet. For urinary incontinence, trying to avoid antimuscarinic drugs. These are part of the anticholinergic drugs that can increase confusion, which are often used for bladder problems. So there's some alternatives that can be tried. Have a look at the Diamond Lewy management toolkit for further information. Thinking about environment, making it easy for somebody to get to the toilet, use of incontinence pads. For orthostatic or postural hypertension, there may be some medications that may be making this worse, so it might be that you need the medication reviewed. Giving tips about standing slowly, drinking fluids quickly, a bolus can really help with reduce some of the dizziness. Excess sweating, you may just need to think about environmental management of this. Now, the excess drooling, which can be quite distressing, we think is linked to the problems of changes in swallowing in Parkinson's. There are some medications that can help with reducing secretions, and again, further information can be found in the Diamond Lewy. For motor symptoms, I will talk about these in a little bit more detail, but the preferred treatment for Parkinson's symptoms is levodopa monotherapy. We mentioned those before. Really important role of physiotherapy, occupational therapy to help maintain independence, and adaptations may help increase independence. And speech and language therapists can be really helpful, particularly if somebody's having problems with speech or swallowing. So the treatments for motor symptoms, just a general overview. Think about exercise, but it may be just some very daily top tips you'll see. So it doesn't have to be going out and doing a marathon, because that really might not be very possible. So there are some adaptations that you can do, but general movement is really important and can be as important as medication. So encouraging somebody to do these things can be really helpful. There are some really useful online videos on the Parkinson's UK website for exercising at home, including seated exercises. So again, people may need encouragement with this, but or if you can get somebody along to some kind of class, because that can be helpful to just in terms of encouragement for people to take part in exercise. Other treatments and therapies are summarised here. So in terms of occupational therapy, thinking about gadgets or equipment to help manage daily activities. Use of cues can be helpful. So particularly if people are freezing and getting stuck, it might be that the use of music or counting can help with that, thinking about the adapting the environment. Mentioned about speech therapy. Speech therapists can help with things like articulation, the facial expressions, particularly when people have a masking. Singing, really helpful for people, but speech therapists may be able to give advice on eating and drinking, and particularly really important around if people have problems with dysphagia or drooling. There's also a range of complementary therapies that can be available, and again, I would really recommend certainly have a look at further information on the Parkinson's UK website if people are interested in those. So we're coming towards the end, and I just really wanted to mention about the impact of Lewy body dementia on families, and really for any cause or type of dementia, we really need to think about how this impacts on the family, and it can be particularly difficult for people with Lewy body dementia because of the complexity of this condition. So a diagnosis of dementia is not just given to one person, it's given to a spouse, a partner, a child, and the extended family. So a lot of the literature talks about particular challenges for families with Lewy body dementia, and some of them are listed here. People talk about a real difficulty in getting a diagnosis, perhaps because of symptoms not being recognised, perhaps services, whether somebody goes via a neurology pathway or a dementia services pathway, some of the symptoms may not be picked up. There are numerous and complex symptoms, as we've heard. There may be poor understanding of recognition by professionals. There's some evidence to say that people with Lewy body dementia have a poor quality of life and well-being. I mentioned the medication risks and the balance of medication, but also really importantly, this severe reaction to the typical antipsychotics in about 50% of people. So real caution about that. The lack of information of post-diagnostic support that's specific to Lewy body dementia, and this is what the literature says, that people say that they don't feel they're getting enough that really relates to their experience of Lewy body dementia. And also sometimes people talk about poor coordination of care. So, you know, perhaps getting stuck between services or things not being joined up very well. So this slide here illustrates the quality of life. You'll see on the left for people with dementia, for people with both Parkinson's disease dementia and dementia with Lewy bodies, there's lower quality of life as compared to other types of dementia. Similarly for carers. So you'll see this is one of the reasons why we think it's really important we do better at getting diagnosis right and getting the support right for this for people affected by this condition. So how do we support families of Lewy body dementia? I think it's important that people get specific what we call psychoeducation. So psychological support and information and knowledge about how to manage specific symptoms, particularly hallucinations, delusions, apathy, sleep. Lots of good evidence to say that individualized, what we call tailored intervention, so adapting the kind of information and support according to the family, the person, really helpful. And this may be delivered either one-to-one or maybe via a group. People needed targeted information. As I mentioned, we've got we're developing further leaflets on the Lewy Body Society website and with Dementia UK about some of the specific symptoms that people really struggle with. And then there also, for people who are familiar with something called the START programme, strategies for relatives of people with dementia. This has been adapted for Lewy body dementia. It can be downloaded and used. So if you're in a service, for example, where you can offer this kind of support, you may want to have a look at that. So that's the end of the session. I really hope it's been helpful. We may be doing a poll at the end of the session just to see how much you've remembered. There's been a lot of information there. I really do hope it's been helpful. There's some details here about our Admiral Nurse Dementia helpline, where people can contact to seek support, but also our close to home clinics. People will be given initial support about Lewy body dementia if they contact either of those services, but also if their symptoms or their experience is particularly complex, then they may be referred onto the Lewy Body Dementia Admiral Nurse service, which is a national service. So please do share this information with colleagues. If you want to find out further information about Lewy body dementia, please do feel free to look at both the Dementia UK website or the Lewy Body Dementia website. I do hope that was helpful.